Hi everyone, welcome back to UWorld's Next Gen NCLEX Review. My name is Samantha. I am a nurse here at UWorld. Happy Nurses Week to you all. So we are so excited to celebrate Nurses Week. Thank you all for joining today. And we have a really exciting giveaway. We're going to be giving away 2 free UWorld subscriptions, 30-day subscriptions. The way that you can sign up to be entered to win is go to uworldnursing.com. You'll hit the yellow subscribe button on the very top of the page, enter in your name, your email. I think it asks you for a couple of other things, and we will look at all the signups in the course of today's lecture to give away our 2 free 30-day subscriptions to UWorld and our full product. So really exciting. We know we're getting towards the end of the spring semester. I bet we have a lot of impending graduates. So save your money on UWorld by winning this free 30-day subscription and head to uworldnursing.com, hit the yellow subscribe button, and sign up in order to be entered to win. This marks the first day of our UWorld Nursing gifting season. So we're going to be gifting lots of different things throughout the week. So make sure if you enter today and you don't win, no worries. You can re-enter on Wednesday or on Thursday. So super excited about all of that. I hope you all enter at uworldnursing.com, again, that yellow subscribe button. Today we're going to be covering one of our most requested topic, and we are covering 5 different topics this week, and they're the 5 most requested topics. So the first one we're going to do is OB, or maternal health. We're going to break our content up into an antepartum, labor and delivery, and care of newborn sections. There we're going to talk about gestational diabetes as it pertains to the antepartum setting, shoulder dystocia as it pertains to labor and delivery, and lastly, newborn assessment being APGAR scoring for the care of the newborn section. So we're going to cover a lot of great maternal health, OB, and newborn content here. Per usual, we're going to have NCLEX style questions at the end, so make sure you stay tuned in for those. We'll also have some questions just to check your knowledge sprinkled in throughout today's lesson. So we will have Nurse Jackie moderating our comments. So stop by, ask any questions, any comments you have, and of course answers to today's questions. Even if you don't have that, feel free to just stop in and say hi. And if you haven't followed us, go ahead and do that already. We will give preference for the gifting to the people that already follow us. So whatever your preferred social channel is, make sure you hit that follow, that like, that subscribe button, because we want to see you here more often. Alrighty, so with that being said, let's go ahead and get started. We'll be revealing the winner of our gifting subscription challenge at the end of today's lecture. So we have about 30 minutes until we reveal the winner, and you all have about 30 minutes to make sure you submit all of your names and emails so we can get that in there. So starting with pre-gestational and gestational diabetes. So there are 2 main different types of diabetes as it pertains to pregnancy. So first we have pre-gestational diabetes, meaning it was already in existence prior to the client ever becoming pregnant. And on the flip side, we of course have gestational diabetes, meaning it's diabetes that is pregnancy induced. So the changes that happen in our body will actually cause impaired blood glucose control. This is what causes the pregnancy induced diabetes. Essentially, our pancreas cannot compensate to produce enough insulin, and the result is going to be that gestational diabetes mellitus. So we're going to look over our gestational diabetes table, and let's go ahead and start out with our risk factors. Now, important to note here, regardless of risk factors or not, some clients will just get gestational diabetes, even having none of the risk factors that made them more likely to get it. On the flip side, you'll see clients that have all of the risk factors, but for whatever reason, still do not develop gestational diabetes. So to some extent, it's luck of the draw. But there are several risk factors that do contribute to the likelihood of this diagnosis. So our common risk factors associated with gestational, remember pregnancy-induced diabetes, include obesity, so a pre-pregnancy BMI of greater than 30, as well as excessive weight gain during pregnancy. So when you go in for your first OB visits when a client becomes pregnant, you will get an expected weight gain based on your pre-pregnancy weight. If you go over this weight gain, you are at a higher likelihood of developing gestational diabetes. Any family history of diabetes also increases your chance, as does a previous large for gestational age newborn, such as just a larger than average size baby. And lastly, something called polycystic ovary syndrome, or PCOS, as it is commonly called. Alrighty, so those are our risk factors. Now, how do we screen and officially diagnose our gestational diabetes clients? So between 24 and 28 weeks of gestation, this is the sweet spot where we screen for diabetes, because this is the time in pregnancy where pregnancy-related hyperglycemia is going to peak. So those blood sugars are at risk for being the highest between that 24 and 28 week mark. So what does the screening look like? Again, between 24 and 28 weeks, we're going to start out with something called a 1-hour oral glucose challenge test. This will happen in a clinic setting, in a provider's office typically. And what happens is the client arrives to the clinic without fasting, meaning they can eat and drink regularly before they arrive. Once they get there, they will ingest 50 grams of a glucose solution. A common name for this is glucola. Now this solution is like a really, really sweet condensed juice. Not everyone is going to be a fan of it, especially people early on in pregnancy that have that unresolved nausea, those food aversions. I know I was an antepartum nurse, and at my hospital we had a fruit punch flavor and an orange flavor, and neither were particularly beloved, but I know that people typically preferred the orange over the fruit punch. So once the solution has been consumed, the client remains NPO for that hour, so they can eat and drink regularly before coming and before ingesting the glucola, but for that next hour they cannot eat or drink anything. Once the hour is passed, their blood will be drawn, and one thing to note is we're not doing a finger stick here, we're doing a venous puncture, so they're taking the labs. A normal result is going to be anything less than 140 at the 1-hour blood draw. That's what we want to see. So knowing this, if our client's results come back as greater than 140, when this happens, we have to officially confirm or rule out a diagnosis of gestational diabetes. So we would then need to escalate to a 3-hour glucose tolerance test. Now, this one is a little bit different, but there still are a few similarities. So this is how a 3-hour test goes. First, the client will fast prior to arriving and taking the test, meaning nothing to eat, nothing to drink for 8 to 10 hours prior to the test. Before they ingest the glucola solution, a baseline blood draw will be taken. We always say we want to know where we're starting before we know where we're going. The client will then drink 100 grams of that glucose solution. So the 1 hour was 50 grams, the 3 hours is going to be 100 grams. And then we're going to have their blood drawn at hour 1, hour 2, and hour 3. So a total of 4 blood draws, because we're drawing our baseline, our 1, 2, and 3 hour. Now, if these between hour 1, hour 2, and 3, if 2 or more of these results are elevated over a specific threshold, that officially confirms a diagnosis of gestational diabetes. Now, you don't need to know each of these specific thresholds. You don't need to commit them to memory because they will be provided on your NCLEX. But our key points to take away to differentiate the 1 hour from the 3 hour is the 1 hour requires no fasting prior, the 3 hour does, and on the 3 hour, 2 or more elevated levels is going to be an official diagnosis of gestational diabetes. Alrighty, so now let's move into our complications of gestational diabetes. We talked about our risk factors, we talk about how we officially diagnose it. Now, what are some of the complications that can arise from this? So let's talk about complications of both pre-gestational as well as gestational diabetes when it comes to risk for the maternal client as well as risk for the fetal client. So starting with that fetal client, the most common one we're going to see is something called fetal macrosomia, or a larger than average baby. Macrosomia is officially a weight that's greater than 4,000 grams, or 8 pounds and 13 ounces. So these are pretty big babies. The biggest complication here is these bigger babies are more likely to lead to a shoulder dystocia during delivery. Now bookmark that because our next topic to talk about is going to be shoulder dystocia, but we're not quite there yet. Other complications revolve around polyhydramnios. Now what this is simply too much amniotic fluid around the baby, which can cause a lot of complications of its own. Now these include PROM, or premature rupture of membranes, and potentially premature birth. This means any birth before 37 weeks would be preterm. It can also cause placental abruption, meaning the placenta detaches from that uterine lining. We're really starting to worry about hemorrhage when this happens, and we're worried about that fetal client being cut off from their blood and oxygen supply. We can also see umbilical cord prolapse. So this is when the cord passes through the birth canal when the client's water breaks. It's bad because the cord prolapses, the blood supply to the baby is cut off. So the baby is not getting perfused, they're not getting oxygen. This is an emergency. Now let's look at our complications for the fetal client. So the baby is at risk after birth for newborn hypoglycemia. Now, how does this work? This seems kind of counterintuitive. Remember that maternal hyperglycemia can lead to the inverse, being newborn hypoglycemia. So they're opposites. This happens because while this fetal client is in utero, they're hooked up to this maternal client that's a continuous support of all the glucose that they need. So the amount that the baby can produce on their own is usually not sufficient to what the environment was like inside of the womb. Essentially, when they are born, they crash because they're no longer hooked up to this continuous glucose supply. And these fetal clients are unfortunately also at an increased risk for stillbirth. Alrighty, now some other complications for our maternal clients. These clients with gestational diabetes will also find themselves at a higher risk for some of our big, heavy-hitting pregnancy-related complications. A big one here is preeclampsia. So quick note about preeclampsia, we do have a whole live on it in case you want more information, but preeclampsia is the new onset hypertension at or after 20 weeks of gestation, plus the presence of protein in the urine, being proteinuria, or signs of end organ damage. Now, if this is left untreated, if it progresses, it can progress to seizures, kidney damage. We can see protein in the urine. We can see clonus or hyperreflexia. So a lot of things can kind of move down the spectrum of acuity here. In our last note about complications, there are a handful of complications that are specific to our clients with those pre-existing diabetes. So these are going to include an increased risk for infection and possible ketoacidosis or DKA, which we learned is a life-threatening acidosis. It essentially means our blood has been overrun with carbon dioxide, and that can be toxic to our vital organs, our brain, for instance. So this is a really dangerous syndrome. Alrighty, so we talked about all these scary complications. Now, what can we as nurses do to intervene and to help these clients? Now, quick note about existing diabetes mellitus. Clients that had diabetes prior to becoming pregnant will most likely need to be followed by a specialist called a reproductive endocrinologist. Now, these doctors really get into the nitty-gritty of insulin requirements, carbohydrate intake, how we really closely monitor, but the NCLEX is testing us as generalist nurses who are not specialized and who are not seasoned. The NCLEX doesn't expect you to have 10 years of specialized experience. It's simply asking you general nursing knowledge. So we're not going to be asked to know the things that a reproductive endocrinologist would know. Instead, we need to know how to teach our client about frequent monitoring of their blood sugar because their insulin needs are going to vary throughout pregnancy. So we're going to keep our nursing interventions here pretty simple. They're going to really be the same we would do for a non-pregnant client. Again, it's the generalist nurse interventions. So in the sense of the big picture, make sure we're teaching the client about healthy lifestyle modifications, promoting a healthy diet, incorporating exercise into their routine. Now, not all clients with gestational diabetes require insulin. Some can be diet controlled, some can be controlled on oral medications. So certain lifestyle modifications in this case will do the trick. We're going to teach these clients how to monitor their blood glucose closely, how to monitor it on the protocol that's prescribed by their healthcare provider. And for those clients that do require insulin, we're going to teach them how to store insulin, how to administer insulin, how to rotate injection sites, all of that good stuff. These clients also need to be educated on signs and symptoms of hypoglycemia and how to manage these low blood sugar symptoms. Now, what is different with a pregnant client who has gestational diabetes versus a non-pregnant client with diabetes is that they are pregnant. We have a fetal client to worry about. So we also need to educate these clients on the need to monitor fetal movement, report any concerns like a decrease in fetal movement, decrease in fetal kit counts. And since these clients have an increased risk of infection, they need to know the signs and symptoms for things like UTIs and yeast infections. So we need to teach them what the signs and symptoms are, and that if they know any of these symptoms, they do need to report it to their healthcare provider. Alrighty, so that sums up our diabetes portion of today's content. That was a lot, but you all did so well. I see someone is asking for a promo code. We do not have a promo code, but what we are doing today, special for Nurses Week, is giving away 2 free 30-day UWorld subscription. So go ahead, hit uworldnursing.com, hit that yellow subscribe button up top, enter your information in order to be entered to win. All you need to do is enter the subscribe button, submit your information, and that automatically enters you. You don't need to do anything else, but make sure you do that. We're going to announce it at the end of today's live, so you still have probably a good 15-20 minutes left. So make sure you do that. You're entered to win and win that free 30-day UWorld subscription. Alrighty, so now we're moving on to shoulder dystocia. And I mentioned this earlier that we were bookmarking it, but now we're going to officially hit it. So shoulder dystocia is a kind of a scary obstetrical emergency, and it requires immediate action to make sure we're mitigating any potential negative outcomes for both our maternal client as well as our fetal client. So essentially what happens here in shoulder dystocia is the baby's head emerges from the birth canal, but that anterior fetal shoulder remains wedged behind the maternal symphysis pubis bone. So in simple terms, the baby's head is delivered through the birth canal, but those shoulders get stuck. So the clinical features, what does shoulder dystocia look like in a clinical setting? It's going to look like the time of delivery is protracted labor, just meaning that labor is slower and longer than a normal labor. This is going to key us in that the baby is not in the optimal position for delivery, and it's either too large to descend into the pelvis appropriately, which ties in again to that slow fetal descent and the protracted labor. This means that fetal station, or where the baby is positioned along the birth canal, is not changing. They're not progressing and moving down the birth canal. And again, this can mean the baby is either too big for the pelvic anatomy or it's simply stuck. So the last thing you're typically going to see, the hallmark sign of shoulder dystocia, is something called the turtle sign. And this is when the head retracts back towards the perineum. So turtle sound is exactly what it sounds like. The baby's head emerges and then it retracts just like a turtle's head retracts back into its shell. It's going to indicate the baby is not moving through the canal and it is likely stuck. So let's look at our risk factors. Now, before we jump into this, does anyone have any risk factors for shoulder dystocia that they already know about? And I'll give you a hint. There's a reason that we tied shoulder dystocia in the same lecture as gestational diabetes. There's a common link there. So if you know any risk factors for shoulder dystocia, now is the time. Drop them in the chat. Let us know what you all are thinking. Marion B on YouTube says, I don't see how we subscribe. Go to uworldnursing.com and hit that yellow subscribe button. It's in the image on the very top of the page. That is where you subscribe to be entered into our giveaway today. Alrighty, and I see some great risk factors coming through. Large baby, macrosomia, that's exactly why we tied together the gestational diabetes section with our shoulder dystocia. I see obesity, pre-existing diabetes mellitus. You guys are totally correct. Way to go, you guys. So some patients will have no risk factors at all and still have a shoulder dystocia. And on the flip side, some clients will have every single risk factor but still manage to not have a shoulder dystocia. Most of the risk factors, however, are aligned with the size of the fetus. So this is of course going to be that fetal macrosomia, or a larger than average fetal size. This is also one of the complications of gestational diabetes. Postpartum pregnancy is another risk factor for shoulder dystocia. So if we're going over or equal to 42 weeks of gestation, the baby grows the quickest in the third trimester. So if you get a whole 2 extra weeks of gestation, that baby is going to grow exponentially. It's going to be larger than average. So these fetal clients are at a higher risk for experiencing shoulder dystocia. Maternal obesity as well as excessive pregnancy weight gain are also 2 risk factors for fetal macrosomia and shoulder dystocia. So again, shoulder dystocia we know is an obstetrical emergency and we need to take immediate action, but we need to know what our actions are going to be in order to do that. So our goal with intervention when it comes to shoulder dystocia is to facilitate a rapid vaginal birth. So what we need to do first is call for some assistance, call in some buddies because you're gonna need some help. Next thing we do is we lower the head of the bed, we get that bed flat, and next we're going to pull up an image to explain this, but we assist in a maneuver such as the McRoberts maneuver. So what this happens is 2 providers, typically 2 nurses, are going to get on either side of this client. They're going to take each leg and sharply flex it back towards the client's abdomen. So we should ideally have the thighs against the abdomen. We're putting those feet almost back to the ears that they can reach. At the same time, one of the nurses will apply suprapubic pressure, so pressure just above that pubic bone of the maternal client. This is going to be applied right to where that fetal anterior shoulder is stuck. So the flexing of the legs helps to rotate that pubic bone and allow that shoulder ideally to become free, paired with the suprapubic pressure applied to the fetal anterior shoulder is going to help rotate the shoulder free of the pubic bone. And ideally, these two moves in unison is going to get the shoulder unstuck and allow for the best chance for a favorable outcome. Again, we want to facilitate rapid fetal birth. We're trying to end this shoulder dystocia and get this child delivered. So back to our shoulder dystocia table that we previously had pulled up, another maneuver that you may see is something called the Gaskin maneuver, which involves getting the mom to go to a hands and knees position. This repositioning can sometimes help dislodge this fetus from the pelvis. Other important things are going to be to document the exact time and events that are happening, just as you would document in a code. So we may be calling out reminders to the provider like 2 minutes has passed, 3 minutes has passed, because this will help guide the healthcare provider for intervention as they're performed and what further ones need to be performed in case we are not able to facilitate that rapid vaginal birth. So complications, as you can tell, it's an obstetrical emergency. It's a pretty scary situation. There can definitely have some repercussions on both the maternal client as well as the fetal client. So starting with the maternal client, these clients can experience postpartum hemorrhage for a variety of reasons. It can even be because of uterine rupture. Really important here is that we apply suprapubic pressure in a shoulder dystocia. We never apply fundal pressure. That actually increases our risk of uterine rupture. Maternal clients can also experience perineal lacerations. Now, these lacerations can range from 1st degree to 4th degree. 1st degree only includes the vaginal mucosa and that perineal skin, so the top layer, whereas a 4th degree includes tearing through the vaginal mucosa all the way through the rectal mucosa, including both internal and external anal sphincter. So that is a very, very severe laceration. Now, our fetal client complications can be neuromuscular, so they can include things like shoulder and arm nerve injury, injury to the brachial plexus, which is that nerve bundle that's right when we turn our neck where it meets our shoulder. And these fetal clients can also have fractured clavicles or humeruses, which sometimes happens as we apply that suprapubic pressure that's needed to dislodge that shoulder from the pubic bone. While this sounds pretty terrible for a newborn to have a broken bone, fortunately these newborn fractures actually heal pretty well. Our more neurologically focused complications are going to be things like a hypoxic brain injury that can lead to cerebral palsy in the fetal client. And unfortunately, shoulder dystocia can even be fatal to the baby because there can be asphyxia from the lack of air. So again, very serious thing. We do want to make sure that we are facilitating rapid birth. We're doing our interventions and we're calling our buddies in for help. Alrighty, so our final section for lecture content today, again, another reminder, I keep seeing asked for promo codes. We do not have promo codes, but we are giving away 2 free UWorld subscriptions. Head to uworldnursing.com to enter, press that yellow subscribe button, enter your information and submit it there, and that's how you will be entered. I will reveal it at the end of our NCLEX style questions today, so just probably 10 minutes from now. Alrighty. So we're going to talk about newborn care only for term babies, meaning babies that are delivered at 37 weeks or above. So first things first, after this fetal client is delivered, it's now a newborn either by vaginal delivery or a C-section, we're going to do a few basic interventions. Now, if you were in a delivery room or an OR seeing this happen, they happen really fast, almost simultaneously, so it can be kind of difficult to differentiate them from another. But our first thing to remember is an acronym called PSDS. It means position, suction, dry, and stimulate. So first, let's focus on position. We're going to place that newborn on mom for skin to skin. This helps with bonding, it encourages breastfeeding, and it helps to regulate the newborn's body temperature. So remember, they went from that warm, cozy environment in utero, and now we're all of a sudden a major drop in temperature as we're in a cold operating room or a cold delivery room. Next, we want to, after we position, is we suction. So we want to use bulb suction, suction the inside of their mouth, suction their nose, and this is to clear out any residual amniotic fluid, help to clear those airways so they can breathe as independently as possible. We also want to dry the baby, and this helps to prevent that cold stress. So it's the same principle as if you get out of a pool or get out of the shower and you get really cold, heat evaporates through fluid. So by drying the baby off, any residual amniotic fluid on them, any of that vernix, is going to help them with temperature control. And lastly is stimulate. So while you're drying the baby, typically you do this kind of simultaneously. You may dry and wiggle a little bit. Essentially, it helps to encourage crying and all things that we want to see to make sure those lungs are working properly. Essentially, we want to have a fussy baby at delivery. Everything in the future, you do not want a fussy baby, but while that baby is delivered, you want them to be fussy, you want them to cry because you want to know that those lungs are working. So simultaneously, as we do the PSDS that we just discussed, we're also going to be assessing something called the APGAR score of our newborn. So before we pull up the APGAR table, do you guys know what APGAR stands for? The APGAR, it's an acronym. They all stand for separate things. As we'll move forward, go ahead and drop the meaning of APGAR into the comments so we know. I'm sure you got it. And if you can only name 1, 2, 3, no worries. Drop in the chat what you're able to do. But APGAR is a tool to rapidly evaluate the newborn's transition to extrauterine life, so life outside of the womb. The score is based on 5 different variables that are measured at both 1 minute and 5 minutes after birth. So APGAR stands for, I see a few answers, way to go you guys, but the A is for appearance or color, the P is for pulse, the G is for grimace or reflex irritability, the A is for activity or muscle tone, and lastly the R stands for respiratory effort. So we have a table for you guys to walk through this as well, but each letter essentially can score between 0, 1, or 2 points, all adding up for a maximum score of 10. So minimum score is 0, maximum score is 10. Starting with that A for appearance, we're going to look for a pink baby. We want to see a pink, well-perfused baby because blue indicates cyanosis, poor oxygenation, poor perfusion. We can observe this via the skin or in a darker skin tone newborn. We can also look at their mucous membranes. P is for pulse. We're looking for pulses that are greater than 100 beats per minute. We can assess this using a stethoscope and count. We can also put a pulse ox on the newborn's foot, which you'll commonly see done in a labor and delivery setting. G is going to be for grimace or reflex irritability. So we're looking for a cough, maybe a sneeze. Most commonly is a cry because these reflexes are typical for a neurologically intact newborn. The second A is activity or muscle tone. We want to make sure our baby is not limp. We want to see them with some activity, some spontaneous movement. They're able to support their limbs and move them around. And lastly, R stands for respiratory effort. We want to assess for good breathing, like crying. We want to see chest expansion. This shows us that the baby's lungs are expanding, air is flowing through, and they are breathing independently. Alrighty, great job, you guys. I see a lot of you guys got the full acronym for APGAR. That is awesome. So let's talk about our APGAR results. Again, we said earlier, we collect them at 1 minute as well as 5 minutes. However, if by that 5-minute mark, if we get a score of 7, this means baby is adjusting well to life outside the womb. Things are going well. However, if by 5 minutes our score is still less than 7, we're going to repeat that score every 5 minutes for up to 20 minutes. Scores less than 7 indicate the baby is not really adjusting as well to life outside the mom. This newborn may need some supplemental efforts like oxygen. If we get a score between 4 and 6, this means that the newborn is having moderate difficulty adjusting, and a score less than 3 means this newborn is in distress. We need higher levels of resuscitative intervention. It's also important to note that we never want to delay resuscitation efforts just to collect an APGAR score. We want to do them simultaneously. And also important to note is that APGAR scores don't predict future neurological outcomes. They are only a measure of what the newborn is doing, how it's adjusting in the here and now. It's not predicative of what's going to be happening in the future. Alrighty, so that sums up our lecture content. We have 3 questions for you all today, and at the end of our 3rd question, we will reveal our winners for the 2 free UWorld 30-day subscriptions. So super exciting stuff. Question number 1, we have a gestational diabetes question. So the nurse is reinforcing teaching with a client who is at 24 weeks gestation and scheduled for a 1-hour glucose challenge test. Which of the following statements by the client would require follow-up? So option 1 says, I will need to fast for 4 hours before the test. 2 is the test involves drinking a 50-gram glucose solution. 3, I should not eat anything for 1 hour after drinking the glucose solution. And lastly, a 3-hour glucose tolerance test is needed if the result of this test is elevated. Drop your answers in the chat. Alrighty. And keep following, keep sharing, and keep signing up for our giveaway, our gifting today, excuse me. Also, as it is Nursing Week, that's why we are doing our gifting session this week. Let us know, are y'all taking advantage of any of the Nurses Week discounts, the freebies? I looked it up and I think Tim Hortons does something. There used to be more. I think there's not as many now, but if you know of any good giveaways or specials, let us know so we can all share in the free stuff. All right, I see lots of answers coming in. Way to go, you guys. How do I enter to win the subscription? uworldnursing.com. There is a yellow subscribe button at the top. Go ahead and hit that and subscribe, and we will draw our winners from the pool of entries that we get during this live. Great job, you guys. And good news, I see almost all correct options. You guys are correct. Option 1 was our correct option. Again, it's a follow-up question, meaning we're looking for our incorrect statement because that requires follow-up. So I will need to fast for 4 hours before the test. This is false. This requires follow-up. We do not need to fast prior to a 1-hour glucose challenge. We only fast before that 3-hour. Options 2, 3, and 4 are correct, therefore they do not require follow-up, so they're not our correct options. A 1-hour test does indeed include a 50-gram glucose solution. We also should not eat anything for the 1 hour after we drink it, and then the blood is drawn. And lastly, a 3-hour glucose test is needed if they fail the 1 hour. So 2, 3, and 4 are correct statements. 1 is incorrect, meaning it requires follow-up and is our correct option. Alrighty, question 2. Here we're going to look at shoulder dystocia. So a nurse is assisting during the vaginal delivery of a newborn with shoulder dystocia. Which of the following actions should the nurse take? Select all that apply. 1 is prepare for a forceps assisted birth. 2 is document the time the fetal head was born. 3 is request assistance from additional staff members. 4, assist maternal client to push by applying fundal pressure during each contraction. And lastly, flex the maternal client's legs back against the abdomen and apply downward pressure above the symphysis pubis. Keep those answers coming. We have a select all that apply. It's our only select all that apply question today. We'll have one more after this, so no worries. I know it's a challenge, but you all got it. Remember what the steps we take, what are our nursing interventions in the case of a shoulder dystocia, and what is going to be contraindicated as well. Alrighty. I see some answers coming in. Way to go, you guys. And again, last chance to sign up for our chance to win a free UWorld 30-day subscription. We are giving 2 subscriptions away today. So make sure you go to uworldnursing.com, hit that subscribe button, enter your information, and that's how you are entered in the pool to win. Someone on YouTube, Maricia, says, I am on the website, but where is it? uworldnursing.com. There is a yellow subscribe button. Hit that, enter your information, press submit, and you will be entered to win. So pretty simple. You guys got it. Keep following, keep subscribing. And you guys have nailed it. Way to go. 2, 3, and 5 are our correct options here. So 2, we do want to document the time the fetal head was born. We call a shoulder dystocia in a similar way that we would call a code. We're making sure we're documenting, we're calling out how much time was passed. Option 3, request assistance from additional staff members. Also true, we want to call in some buddies. You're going to need 1 nurse on either side of the client to fulfill that McRoberts maneuver to pull those legs back. Someone needs to apply suprapubic pressure, so we need some buddies to help us do this. And lastly, 5, flex the maternal client's legs back against the abdomen and apply downward pressure. This is describing suprapubic pressure as a part of the McRoberts maneuver. We would want to do that. So option 4 is contraindicated. We do not want to do that. Fundal pressure will increase our risk of uterine rupture. We apply suprapubic pressure, not fundal pressure. So we would not do option number 4. But way to go, you guys. And lastly, we have an APGAR question before we reveal our winners. So the nurse here is assessing a newborn at 1 minute of life. The nurse notes the newborn is completely blue, has a heart rate of 110 beats a minute, is emitting a weak cry, The newborn has active movement of extremities and grimaces when the nares are sectioned. Which of the following APGAR scores should the nurse assign the client? So is it 4, 5, 6, or 8? Go ahead and drop those answers in the chat. Let us know what our APGAR score is going to be here. And after we reveal the correct option to this question, I will also be revealing our 2 winners for the free 30-day UWorld subscription. So super exciting stuff. Again, happy Nurses Week. Alrighty, keep those answers coming. Someone is saying it's option 1. Someone is saying it's option number 3. Let's get a few more answers and then I will walk through this with you all. Alrighty, great job, you guys. I see a little bit of variation here, so let's walk through this one together. APGAR, again, it's an acronym. We're going to start with that first A, which stands for our appearance or our color. So the question notes that the newborn is completely blue. So between 0, 1, or 2 points, we're going to give 0 for a completely blue newborn. So far we have 0 points. P is going to be our pulse. It is greater than 100. Awesome, that gives us 2 points. We're now at 2. G is going to be that grimace or reflex irritability. And the question states that grimace when the nares are sectioned. We get 1 point for that. We're now at 3. Then we're going to move on to our activity. It says active movement of the extremities. That gives us 2 points. Now we're at 5. And lastly, R is going to be that respiratory effort. It says a weak cry. This gives us 1 point. 5 plus 1 equals 6. We have an APGAR score of 6, or option number 3. So way to go, you guys. Great, great job. I'm going to go ahead and reveal our winners. And we have Emma W. and Francisca H. So Emma W. and Francisca H. We have your emails. We will be reaching out for you guys. Let us know if you're still here. Congratulations. That's so exciting. We're going to be giving something away every day of Nursing Week. So if you didn't win, no worries. Come back on Wednesday or Thursday for another chance to win. Quickly, we're going to look at our QBank slide. Again, for any of our existing UWorld users, here's how you get more questions based on today's topic so you can challenge and test your knowledge. It's also great to see for any of our prospective buyers who are looking into buying UWorld. I know that graduation season is upon us, and a lot of you guys are going to be hitting that study session hard prior to taking your NCLEX. So thank you so much for joining today. Again, congratulations to Emma W. and Francisca H. Congrats. It's so exciting. All of these lives are on demand on all of our social channels. The YouTube is going to be the easiest one to search, so I would recommend doing that. Come back tomorrow at 11 a.m. and 7 p.m. Central Standard Time for more nursing question drills. And thank you so much for joining today. I will see you guys soon. Happy Nurses Week.